Thanks, Minerva. Good morning, everyone, and welcome to the WellMed Charitable Foundation Caregiver Teleconnection session entitled Understanding and Managing Behavioral Symptoms of Lewy Body Dementia. And we are so pleased today. I can't tell you, we have Brandi Hackett, who comes to us from the only national organization that provides information and resources for people who are interested in learning about Lewy body dementia. So Brandi, it's all yours.
Thank you so much, Evelyn and Minerva, and I'm very honored to be here today. I'm going to go ahead and share my screen, and then we'll get started on the presentation. Okay. Again, my name is Brandi Hackett. I'm the Senior Manager of Support here at the Lewy Body Dementia Association. We'll talk a little bit more about our association in a few slides, but we are based here out of Georgia, but we do serve nationally. A little bit about me and my background. I am a social worker by training. May was my 19th year that I have been supporting individuals and their families, primarily working with older adults. But I have been here with the Lewy Body Dementia Association. Actually, this Thursday is my 3-year anniversary with the association. So I've been here for 3 years serving in the role of support. Took a leadership position here in support in January, and very, very honored to work not only with our staff here, but our national network of volunteers. In terms of the presentation, we will not be sharing the slide deck after the presentation, but I will be providing, as Evelyn mentioned, quite a few resources that you can use to help to answer questions, to help as resources as you are having conversations with the medical professionals that are involved, et cetera. And always a reminder that anything that we share is sincerely for educational purposes only. This is in no way, shape, or form in place to replace the diagnostic criteria, guidance, or care that is provided by medical professionals. And we are, as an organization, committed to diversity, equity, and inclusion in all of our care. So on the slide is an actual Lewy body. And so the understanding at this point is that it is an accumulation of a certain protein called alpha-synuclein. And this is a very different protein than what can be seen in some of the other dementias. And they're still trying to figure out a lot of the why, but for some reason, this protein that is necessary in our brain clumps up and creates a Lewy body. And that's the reason behind the symptoms that we'll talk about today. So this is defined as a progressive brain disorder that is affiliated directly with those abnormal protein deposits that we mentioned, and those are called Lewy bodies. And those were originally named after neurologists that in the early 1900s found this clump of proteins. This label, Lewy body dementia, really encapsulates 2 different conditions. One is called Parkinson's disease dementia, or PDD, and one is called dementia with Lewy bodies, or DLB. There's really the difference between is going to be what surfaces first. So typically if a person has an established diagnosis of Parkinson's disease, and then a year or more later develops changes to their thinking and memory, and some of the other symptoms that we'll talk about today, this may be referred to as PDD, or Parkinson's disease dementia, a type of Lewy body dementia. If a person has sort of the flip of that, where the changes to their memory and thinking, altered perceptions that we'll talk about, et cetera, surface first, and then alongside or later they develop the changes to their movement or motor functions, this can often be called DLB, dementia with Lewy bodies, again, a type of Lewy body dementia. So today when we use that term, Lewy body dementia, we're really speaking of everyone under that umbrella. And so what I want to do is I want to dig into not all of the symptoms. This would be a much longer presentation today, but I want to focus on the ones that we get the most calls about on our helpline. So this is going to include changes to cognition or memory and thinking, changes to sleep, and then changes to the altered perceptions that a person can experience as they have this diagnosis. So one of the key factors that can make this dementia very different than some of the others is this cognitive fluctuation that can happen. Sometimes I describe this as almost like being on a dimmer switch. So it can be a bit of an on off, a bit of a times when things are better, that the person has less of a symptomatic presentation, and times when they struggle more. So this can look like different abilities in terms of attention span, concentration, clarity. Many who are supporting this diagnosis or experiencing this diagnosis may experience something that sometimes we refer to as showtime. We tend to see this very frequently in front of physicians or medical professionals. We may also see this in front of the one child that swears nothing's wrong with dad or mom, the neighbor, the person at church, etc. But I do not believe sincerely that it is a faking it piece, that it is truly a spike in one's ability where they're able, just the same way that I say we all clean our house for company when that comes over. It's an ability to pull together. Now, what we tend to find is this becomes more difficult over time. The person may also experience periods where they're almost zoned out. And I'll hear this both from the caregiver's perspective, but also from the person living with Lewy's perspective, is sometimes it's just sort of blank. And you may also find that the person experiences these episodes of daytime sleepiness. So even if they had what one would consider a pretty normal night's sleep, they may doze on and off. I had one gentleman in our group said sometimes it just feels like narcolepsy, just sort of like dozing off throughout the day. So cognition, if we go back, I love Melissa Armstrong's, who's a neurologist out of Florida's definition. She calls it thinking and memory. It's a simple way to think. And so for us, I think if I were to take a microphone down the street and say, you know, what is dementia? Most people would say unable to remember things, loss of memory. And so this specific dementia can present very differently. And so not only can we have some memory loss, especially in later stages, we do find that there is a larger change in terms of the way people think. So the way that they process thoughts. And so we'll go through a couple of these subsets right now. So attention span, a lessened ability to concentrate, lessened ability to notice small things that are going on, especially social cues. And if you can imagine, if these are difficulties that you were experiencing, the misreads within social situations, within personal situations, remembering things. Sometimes this can actually look like memory loss because, as one person recently described to me, she said, sometimes I feel a little bit like a butterfly landing flower to flower to flower, that I'm just less able to focus. And this can also show up in things like reading. So you may have people say, I just can't get off the page. I just can't stay focused. Or it may show up in things like reading a recipe. So if you understand that if you lose focus in the middle of a recipe, it may not show up in the way that you intended. Executive functioning, this is sort of how we are the CEO to our day. So how we manage the way the day gives us things to do. So this can be everything from simple grooming tasks to how we manage lawn maintenance. It may mean how we are handling things at work or things in a parent role or a grandparent role. It definitely can affect planning. It can affect multi-step tasks, sort of the ability to go into a situation and say, this could be a solution. This can also show up in things that were previously easy for the individual. So they may say things like, man, it used to take me 5 minutes, now it's taking me 5 days. And so just that lessened ability to pull it together. And what we find, especially for those that are still working or those that are still in higher pressure situations, that sometimes when there is that pressure, just the same way for any of us, if we're under pressure, we're just not thinking as clearly. And so these can really float to the surface when stress is involved. We'll skip, sort of work our way from the bottom up. So memory loss, memory changes can definitely be a part of this dementia. But what we often find is a lot of this sort of screening tools for cognitive losses or cognitive changes are really memory focused. And so sometimes a person having a Lewy body dementia may present really well on sort of a standard memory screen. And so you may find that the changes to their ability to remember would come over time, but for many, they are spared, especially in the beginning. When it comes to language, language is both providing content and receiving content. And there can be difficulties in both realms for that. In visuospatial, there's actually a really incredible presentation that was just done here at LBDA on vision changes in Lewy. And so it is a bigger part of a much larger conversation, but visuospatial is really our brain's ability to manage the way our body is in the space around us. So if you can imagine just difficulties in your brain judging distance, for example. So if I have a cup here and I go to put it on a table, it's very important for my brain to read correctly the distance to the table. So if it doesn't, I may drop the cup on the floor. If it oversteps, I may knock the heck out of my elbow and have a lot of pain there. And so it's extremely important, and our brain does a pretty good job overall managing sort of how our body is. And that can also show up in an extension of our body. So if you imagine that when you sit in a car, the car is sort of an extension of you. So the brain is doing very similar processes to distance to the stop sign, distance to the pedestrian, distance to the sidewalk or to the middle lane. And so sometimes there can be misread in terms of some of those literal distances, but also it can show up in things like double vision, color contrast. And if you look at some of the other symptoms, which we will not cover today, but things like some of the autonomic changes, which can lead to dizziness, or some of the other motor symptoms, because of the relationship with Parkinsonianism and Parkinson's, you can understand that if your eyes aren't working correctly to give you the information, that it can show up in different ways. So this may lead to falls. It may lead to car accidents. It may lead to bruising because of people hitting walls. Or I've had a couple say that they thought the couch was closer, so that when they went to grab it to sort of steady themselves, it wasn't there. It was further than their brain had told them. So this can really show up in a lot of different ways, but it's part of how the brain is interpreting visual input from the eyes. In terms of sleep, these are sort of the three buckets that we see the most concern. Restless leg in the middle is going to be the least frequent that we hear about, but it's really like just an uncomfortable sensation in the legs where you're just like, oh, got to move them, got to shake them, got to change, got to, it's just this sensation where you just have to move. Insomnia, most people are pretty familiar with this one, or they've heard of people having issues either falling asleep or staying asleep. And we know that Lewy isn't the only cause of people having issues with insomnia. So they may also have, for example, an enlarged prostate, which has them getting up and down all night with urination, et cetera. REM sleep behavior disorder is a more unique condition, but very much can show up in, I would say, the strong majority of those, at least for one occurrence, if not more. And this specific symptom can surface sometimes for some decades before the other symptoms may surface. And so what this is, it's basically our body has a natural ability or tendency when we get into certain phases of sleep to still. So when our body is dreaming, our brains are really active. And in those times, our body sort of gives us the gift of stillness. And so why this is called REM sleep or rapid eye movement is often when our body is that still and we're dreaming, you can actually see movement in the eyelids. So you may see a flicker behind the eye. And so that's why it's sometimes called REM sleep or rapid eye movement sleep. And what happens, and again, they're trying to figure out a lot of the reasons, is that natural switch that keeps our body still in those moments stops functioning well. And so what happens is our very, very active dreaming brain has a body that's reacting to those dreams. And so what may happen in those moments is the person may yell out, they may get up, they may sling and hit a bed partner or hit their hand on the dresser, or they may roll out of bed. We've had a couple sleepwalk, have various injuries. I had one report that they actually hit a mirror and had the glass break. And so it can be very dangerous as well, because again, the person's asleep, but their body and their brain are very much awake in those moments. So it can also be important to know that there are certain sensitivities to medication that we do see in a majority of those that do have Lewy. And so this may be medications that are available over the counter, such as Benadryl. It may be, and most often is, medications that you would get through a prescription or from a medical provider, such as Haldol. And so what we find with some of these sensitivities is that they work sort of in the opposite spectrum. So for some, the wrong medications can cause almost like an extreme worsening of the symptoms. So instead of them getting better, they get worse. And so the medicine's intended to do one thing and it really does the opposite. For others, it can be really an extreme worsening of movement. I know one person said that their loved one, it's almost like all of the movement or motor symptoms with the Parkinsonianism became with very quick onset. And so it's almost like a stiffening, a muscle rigidity that can happen. And we have had individuals that have also had things like fever, organ failure, et cetera. And I say this just to say that if you're supporting someone that has a suspected Lewy or a confirmed or probable Lewy, that it is very important to be familiar with these sensitivities of medication, especially in situations such as hospitalizations or under hospice care. Another piece with the meds that we want to be sensitive to is sometimes it's a balance. And so, again, if we go back to some of the motor symptoms or motor changes that can happen, sometimes the medication and those buckets of symptoms can make the visual hallucinations worse. And sometimes the meds that help the visual hallucinations can make the motor symptoms worse. And so it can be a real balance in discussions with the physician that if you notice a very acute change, in either to have those conversations to make sure that the balance is best for your loved one. And this balance isn't an official space. So it's not that everyone with this diagnosis needs to take this amount or this amount. It's often quite a bit of an art form to figure out what medications are best for the management of your person's symptoms. We can see a host of symptoms that can come up, and this screen highlights a few. We're going to talk about a few on this slide, but we do see biochemical changes and cause to feelings of depression and anxiety. We also see something called apathy. And apathy can at times be associated directly with an depression. So most people, if they've seen someone with apathy, they will say, oh, it's because they're depressed. But with this diagnosis, it almost stands on its own feet. So for some, it's sincerely, it's been described almost like it's just a lack of get up and go, a lack of motivation, a lack of inspiration, a lack of finding joy in things that once they did. And this can be really frustrating for care partners that are supporting because they're like, come on, we know you need to, and fill in whatever blank that is, whether it be see family, do this thing, have this thing, do this test, do this activity. And it's sincerely, I had one gentleman describe it, it's almost like their body's made of concrete, not in a physical sense, but almost like an emotional sense. And so there can be some support around that. Some have found benefit in medications around that, therapies, et cetera. We're going to spend sort of a bit more time on the three that are on the right-hand side of this circle. So this is going to include hallucinations, delusions, and illusions. So a hallucination is an experience using our senses that others don't experience. So with Lewy, typically, I would say for the majority, they're going to be visual. But for many, it can be a combination of sensation or sort of exclusive sensations depending on the situation. There are times when these are really simple, so they're not going to be with detail. So they may be vague, a sense of presence. I had a gentleman describe this to me most recently, and he said, I just feel like my kid's at home. She's not. She hasn't lived here in years, but I just feel like she's here. Now, that doesn't mean that they're seeing their person necessarily. It's just a real sensation. So if you imagine that there's a loved one of yours in another room, the knowledge of that. So that doesn't mean that you're physically seeing them, but you just know they're there. So you may have heard the back door open or not, but you may know, oh, well, so-and-so's in the study. It's just that awareness of. Sometimes that involves someone that's deceased or a pet but it's a sincere sense of presence that's really hard to describe. For others, it can be sort of seeing something out of the corner of their eye. So this may be a shadow, it may be something physically there, but their brain is misinterpreting it as something else. We have a situation of this where a lady was complaining that she couldn't sleep because the man was standing over her bed lecturing her. And so the daughter actually went into where she was staying in the assisted living, and I said, flip off the lights and see what you see. And so she did. He called me back and said quite a few cuss words, not at me, but at the universe. And she said, Brandi, she's always cold. So I put the coat rack full of her coats at the head of her bed so she could always find them. And if you think of us lying down and looking up, it would be easy to perceive that our brain may misinterpret that a coat rack full of coats at the head of our bed may look like someone sort of standing over us. Now, those are the simple ones, and sometimes they can be extremely detailed. Now, these may again show up with any of the senses, so they, again, very often visual, but that may be something that they hear. So they may say, hey, I heard someone knock the door or someone call my name. I have one gentleman that frequently has smell-based hallucinations, and his happens to be bacon, which he loves. And so how disappointing for him to have that sensation and that sensation not be true. Some have had taste or taste changes or feelings of certain things on their skin. I have one that described like feeling of like a light spider crawling across their forehead. And so as they're experiencing these things, it can often be to the same level of realness as you and I have. And so often the response is extremely appropriate. So if anybody on this call heard someone calling their name, we would all respond in a pretty similar way. Or if there was a knock at the door, or if we had a spider crawling across our forehead, we would probably have a very similar reaction. These can show up early for this diagnosis, and for some, it can be one of the first symptoms they may experience. They're not always scary. So a lot of people will say frightening or fear or they're afraid of. And there are times, yes, they can be, very much so. But often, again, if we go back to normal feelings around these things that we're perceiving, sometimes it's not fear, but it may be annoyance, for example. So we had one gentleman who I talked to an adult child, and they said that the gentleman had a host of Barbie doll-sized people staying in the room with him at the independent living. Now, he wasn't scared of them. He actually enjoyed their company. So there was nothing wrong with their presence, but he was really, really frustrated, honestly, because he thought he had to pay for their stay. So he was upset with the bill that he thought he was going to have to pay, not with their presence. And so for some, we get a lot of people that describe small versions of people, pieces and parts of people. Lots of children are reported, sometimes furry animals. We actually had one gentleman who, it took a very long time for him to identify that it was a hallucination because it was just a dog outside. So he kept seeing this dog, learned after a while that no one else was seeing the dog, for example. Now, delusions. Delusions are similar, and sometimes people will use the word interchangeably, but they are different. Now, as I like to describe, sometimes these will dance together with visual hallucinations and other hallucinations, and so they can walk hand in hand. But these are different because unlike perceptions that you're experiencing, these are thoughts that are stuck. So you have to think it is a false thought, brain lie, as sometimes I call it, that is fixed in the brain. Now, this doesn't mean forever. It can ebb and flow. But basically, it's a stuck thought. And there are several types that can cause very real emotional reactions by these individuals. On the screen, there's some of the common ones that people will describe. One of the ones that I mentioned before is going to be sort of the presence of people that are in the home. And so sometimes phantom boarder is what you may hear this officially called. So it's sort of like ghost roommate. So they may perceive a person in the home that doesn't typically stay there. and often with a lot of detail. So I have one lady's daughter that reported that her mom actually talked about the lady living downstairs, which no one else could see or experience. And she had actually told the daughter that the lady got a haircut and it looked great. So it was with incredible detail that she was able to describe this individual that was staying there. Othello was especially hard. So this is a sincere belief that a spouse or partner is unfaithful. And that's a hard thing to be on the other side of as a spouse partner who often is doing their best to provide support to their loved one. And so these stock beliefs for the person can sometimes come out in accusations of those that are closest to them. And the receiving end of that one is very hard because you want to prove that there's faithfulness, but for them, it can be really stuck that there's not. And sometimes things can happen in the real environment. So had one lady describe that she rushed in, put groceries on the counter, dropped the keys on the counter. Putting groceries up, and the husband came in and he had a lot of these specific delusions. And he said, well, it's obvious that you went to see your boyfriend because the keys aren't on the hook. So again, the thought was stuck in just the same way that if we have a thought, we look for truth in our environment. We look for things to back up what we think is true. So right now, daytime, and if I were to say, hey, everyone, it's daytime, maybe different times where you are, but it's daytime. Our brain naturally gives us content to back that up. It's not something we have to seek out. So you may say, oh, it's the time of day for daytime, or it's the sun's out, or it's et cetera, et cetera. But our brain is sort of taking and looking for content to prove that that thought is correct. And this is what can happen, even if the thought is incorrect or a brain lie. Capgras or capgras, the first one, is very, very hard because the misidentification syndrome and part of staring at a person and not recognizing them as who they are. And this can be hard, again, when you're trying to provide care for someone and they're looking at you and they're saying, you know, where's Evelyn? And she's like, here? I'm right here. No, Evelyn. I've got to call her. She's not here. And they call, and the phone literally rings, and they answer it, and they say, hey, I'm right here. And they can physically see you talking, and they're still not identifying you as you. Really hard, too, with intimate relationships, very hard in terms, because, again, if I'm misperceiving you as the correct person that I'm looking for, I'm going to keep looking for the person that I'm looking for. And so sometimes it's especially hard because any of these things that are experienced are often leading to very, what I'm going to call real, and have to be careful saying, appropriate reactions to the brain lie. I'm not saying appropriate as in making your life easier or something that's easy to deal with. I'm saying if any of us were having these thoughts, often we would be responding in a very similar way. So I hope that makes sense. So if we look at the next to last, Ekbom, sometimes we'll see this in infestations of food in front of us. So again, we could pass the talking stick through this whole call and say, if you look down and saw maggots in your food, would you eat it? And most people would say no. If we saw it on our skin, would we pick at that until it's gone away? If we were in a room and there was an infestation, would we want to stay there? Would we feel comfortable getting into the bed if we saw certain vermin or parasites or insects? Not recognizing self in mirror. This one had a very real thing that happened from it, where the gentleman actually stopped showering. And it's because he finally said, I will not get naked with that man watching me. And they looked, and it was a full-length mirror on the back of the door. So again, what I'm trying to explain is, yes, these can happen, and they're very, very hard to support from a caregiver standpoint. But often it's understanding that their reactions are often normal, like any of us would to these brain lies that are happening. So we know these symptoms happen, so what do we do now? And so right now there are primarily great ways in many situations to manage. And so there can be some techniques, and we'll talk about those. There can also be some medications in certain situations that can be supportive or helpful to help manage the symptoms. There are not currently treatments. We're hopeful in the pipeline, and there's some hope in the future, but there's no current treatments to affect the progression of the diagnosis itself. But there are medications and other treatments and techniques that can help to manage symptoms. So if there is a spike in these conditions, if there is a change, if there's a worsening, or if it's just there and you're like, what in the world can I do? Sometimes it's really helpful just to make sure there isn't a physical cause. So things like constipation, pain. We had one person with a severe ingrown toenail that just wasn't able to express that, and that pain sort of radiated and sort of showed up in different ways. We also want to look at things like infection, urinary tract infections, pneumonia, but there can be certain physical things that can change that can sort of surface or show up in a worsening of other symptoms. Sometimes it's medication. So we talked about that double effect in terms of meds. It may be a med that they've been on for a long time. It could be a new med, an increase of med, a different timing of med. It can be important if there's a sharp change just to touch base with the medical professionals. If we go to those environmental or social factors, there can be techniques that can change and can support. So if we go back to the gentleman that would not take a shower because of the man watching, they took down the mirror, and guess what? It helped. With the lady that was lying in bed looking up and seeing the person looking over her, they moved that coat rack. So sometimes it does take a little bit of private investigation to look at it and say, is there a repositioning? It may be the way that the sunlight's coming in at a certain time of year, casting shadows on the wall that are being misinterpreted. There may be difference in technique in how we're supporting. So the example I always give, so if Evelyn came running up to me and she goes, Brandi, I'm being chased by a bear. And if I said, Evelyn, oh God, I told you, the bear is not real. I need you to sit down and have your breakfast. In the end, what I have discovered in sitting with these families and in my career and in talking to people that are diagnosed, that are experiencing these, it really boils down to we all as humans want to feel loved and heard and safe and understood. So sometimes our reaction, although we do it in a way that almost makes sense, it makes sense to us for me to tell Evelyn there is no bear, because if there is no bear, then she should feel better about freaking out that there's a bear. So part of me wants to lean in and just say, you're fine, it's fine, there's no bear. And as well-intentioned as that can be, in those moments, if this is as real to them as anybody sitting on this call, sometimes you have to sort of come at it backwards. So first I say, take a deep breath, step back and say, what would I need if? So if this was the brain lie that I was experiencing, what would be helpful to me to again feel loved, safe, heard, understood? And try those things. It's not magic. It's not always helpful. But if we look at the misidentification in Capgras, and let's say Evelyn said, oh, okay, let me go grab Evelyn. She's in the other room. And Evelyn leaves the room and speaks from the other room before the eyes catch. Hey, Jim, I'm on my way back in. I got this beautiful new blue shirt I can't wait for you to see. So he can identify verbally that that's Evelyn, hopefully. And then she enter the room. And then although he may have paused, it may help blip that system that he's able to sort of pull out of some of these brain lies. So there can be techniques, and there's some of the resources that I'm going to provide you guys. There is a wonderful video from Mayo, Minnesota about supporting through technique some of these altered perceptions. And then, so those are really what we call those non-pharmacological approaches or techniques. And then looking at meds. And sometimes this is a very quick process. This is not a step one, it takes a week, step two takes a week, et cetera. These are often working in tandem, but important to know that yes, there are medications that can be helpful to some for the management of these symptoms, especially if they are causing major changes to the quality of life of that individual and their care partners. There can also be crisis situations. And so as I explained to everyone, we want to really assume that the person on the receiving end does not know Lewy. That needs to be our walk-in assumption. It's unfortunate, but it needs to be our walk-in assumption. And so sometimes having things like the medical alert card, which I'll also provide, other ways that we can provide very quick information to medical services, paramedics, police about the condition, because we know in the worst of times, this can mirror things that can benefit from other meds, other techniques, appear like mental illness, etc. So it can be important to have sort of quick ways to provide that education. We also know that sometimes it can involve legal. So this may involve things like guardianship or conservatorship proceedings. It may involve actual legal proceedings. So this may include things like domestic violence or intimate partner violence. It may include a certain aggression towards other people or strangers. This can be challenging for care partners and challenging for those that are experiencing these symptoms. And so these cognitive fluctuations of up and down, down and up, having a lot of inability to predict what that's going to look like. Also things beyond the changes to thinking and memory. So these walking mobilities, falls, blood pressure issues, sleep schedules that are interrupted, etc. These, what we call behavioral symptoms, altered perceptions, changes in mood, changes in apathy. Again, these can start early and can be hard to support. And for many that I hear from, the person experiencing these changes, it may be a first for them. And it's very frequently a first for the care partner. So again, we shouldn't assume that we should know what we're doing because we've never done that before. And we know our activities of daily living may need support earlier. There can be physical, occupational, speech therapy counseling for both the individual and their care partner. And we as an organization really do lean into trying to provide additional information, such as this educational program, but also print materials, publications, other events and outreach, helping individuals and their families access education and research, and then providing the support that we mentioned. We currently have 4 closed Facebook groups, one only for care partners that are diagnosed, one only for those living with Lewy through their own Facebook profile. We cannot accept a care partner's Facebook profile to get someone in. And then we have one that's a dyad group. We're going to be repositioning that third one soon to do a little bit more support in terms of those that are with a newer diagnosis. And then Beyond Lewy is our Facebook page specifically for those in bereavement. We have a host of publications, which I'll provide. We also have a monthly newsletter, Facebook page, Instagram, and I'll make sure you guys have these links as well. And lastly, I want to stop on this slide, and I'll leave this up as we are processing some of the questions, but these are the best ways to get back to support. So we do have a 1-800 number. You do leave a message. We do try as quickly as we can to get back to you with questions, answers, and support connections. We also have a support email there at the word support@lbda.org. And that's a great way, especially if we're unable to get to your question today. Feel free to take time to reach out to us directly, and we will do our best, Tori and myself, to respond to you and then to help facilitate connections with lived experience volunteers, different types of support, and other additional education. So thank you, guys.
Wow. Brandi, that was fabulous. I took so many notes. I can't believe it. I just want to say that we would love to hear from you folks. We hope that we can get to all of your questions. Actually, right now, we only have one chat from Minerva, which is a really good question. At what age does Lewy body dementia start to make an appearance?
So in terms of age, I can tell you the majority we do see over the age of 50. The youngest I've supported through the helpline was in their 30s. The oldest was over 100. So it's a large age band that we can first show, but I can tell you the majority is after the age of 50.
And Brandi, is that bear still behind me?
Nope, you're good. You're good.
Come on, folks, more questions. That was a heck of a lot of information in a short period of time. So if you need anything explained, I kind of wondered what the gas bar, what those acronyms were for after the different types of.
Oh, I'll go back to that slide just so we can reference. So the capgrass here, is this the slide that you're referring to?
Yes, yes.
Okay, so the words in bold are what you may see them called in research. So you may see them referred to. So I prefer to know them as they are because it's often not helpful to know a word unless you know what the word means. And so I would rather share sort of like what it feels and looks like. But you may see in some publications these referenced as, like, for example, not recognizing self in mirror may be called mirrored self-identification. Othello, Cotard reduplicative paramnesia, that is such a mouthful. So you may see this in different articles, but that is sort of, I guess, the formal title or name that you may see. But then really, like I said, I prefer to simplify things and just make sure that there's an understanding as opposed to a new vocab word.
Oh, thank you. And we have Sharon Collins, who has her hand up, and she's unmuted. Go ahead, Sharon.
First of all, thank you both so much for this. My husband's diagnosis didn't take that long to get. We're very grateful for that. And so we've been sort of fully into it since the end of June. My question is, and first of all, I want to thank you for all your resources and mostly for the non-pharmacological ones. I love those and the practical resources because that really cuts down on the frustration for the care partner, right? It really does. So I just cannot thank you enough for that. My question would be, and it's sort of relative, is about the driving. You know, it's so, you know, if you haven't been told by the neurologist or the whatever, and you're just sort of gauging, I guess that's sort of, I don't know if you have any suggestions for that other than just gauging, right? Because, you know, we know that that part of their brain, the routine part, the habit part, right, functions fairly well. So that's a great thing, right, for Lewy body folks. It's just, you know, you don't want to wait for the first accident. You don't want to wait for the first, they put it in reverse instead of drive. I'm just curious, what do you hear most often with that? Thank you.
And thank you for a great question, Sharon. I wish, like any of this, that there was an easy answer. Driving is very symbolic. It is our freedom, it's our independence. So I like to think of it first. I love, and this is not my term, I just really stole it. I love the concept of driving retirement. So to me, I like that positioning as opposed to giving up the keys, taking away, you know, I feel like that can be a little kinder in terms of not only understanding the experience, but really trying to put tools around it. Lewy is complex because Lewy is not just changes to memory. It's a lot of physical changes too. So sometimes with driving, I have found that it can be important to sort of broaden the scope of that conversation. So for example, because of this connection to movement or motor changes, sometimes referred to depending Parkinson's or Parkinsonianisms, sometimes those will result in slower reaction times, reduced movement in the neck, etc. And so sometimes those can be a little easier to crack open that door as opposed to saying because you're seeing, doing, feeling, or thinking differently. So sometimes I would say use that golden opportunity when you can. Because of those motor or movement changes, just I hate to say take advantage of that, but it can be a bit of a golden ticket. When it comes to some of the other things, I don't love scare tactics when it comes to driving because I think there's a lot out there. The unfortunate part is a lot that's used in scare tactics are real. So things like increased liability if it is found, if there is an accident, that the person has dementia and really should have not been driving, et cetera, et cetera, et cetera, et cetera. So yeah, that does exist. So I do think being honest about some of the increased litigation liabilities in terms of if something were to happen, then this could be used. Sometimes I'll throw in there with some cushion that, you know, our funds are what gives us options to be able to choose care. And so if we have an automatic reduction to our assets, that can change our options. And so for some, again, a little kinder door to walk through that makes sense. It's not just hand flap, hand flap, hand flap. So those are a couple things there. When it comes to the vision changes, a lot of times those are experienced but not understood. So leaning into the visual changes as physical changes to the brain interpretation And sometimes what I have seen is that a deeper understanding of the visual changes has helped people understand the risk a little better. And so again, I'll share that vision presentation. It's long, but some caregivers have used that, watched it, and have used that to help design that conversation. There's a couple great publications. Hartford has a ton of publications. I'll send you guys some that have ways to position the conversation. Sometimes it's the who that's chosen to have the conversation. So sometimes it's not the spouse. It's the one adult son that they trust, whatever, or an attorney or a financial planner or a physician. Sometimes it's time of day. So taking advantage of more of an on period. In some situations, sometimes more of an off period when they are showing more symptoms, just to use certain examples. So again, it's an extremely sensitive situation. It's also one of my favorite stories of my entire career. I had a daughter take her mom's keys away, and she felt bad. And so the daughter went back to go comfort mom, and mom passed her on the road driving.
Oh.
And basically the lady had actually called the car dealership and said, I lost my keys, and they came out and made her a new set. So sometimes people will continue to find ways to get from A to B. And so it's also important to also think of other things such as bikes, motorcycles, golf carts, lawnmowers, boats, other things that can be ways to get from A to B, trains, planes, and automobiles, just to make sure that you're thinking through some of those things too. Because I have seen people, if things are taken away without real conversations, they'll find a way, A to B. So just being sensitive. So I know that probably wasn't the direct answer you needed, but hopefully that's helpful.
That was a great response. Anybody else? We've got some time. We would love to hear from you. Your questions really are, important for everyone online here. And they'll also really help our podcast, be more rich. And I think answer questions that people may have. Okay. So what's
There's
the
a lot
average?
in the chat.
I'm sorry?
Check the chat.
Thank you. Check the chat. I keep checking it. All right. Chat. Anna Marie?
Hi. I asked a question, how can I find more information about the different types of Lewy body? For example, cortical Lewy body dementia versus Lewy body dementia.
So there are certain conditions that fall under a larger umbrella called sort of atypical Parkinsonian syndromes, diagnoses. Sometimes that word's used in different ways. It sounds like what you may be describing. And so the alpha-synuclein piece that we talked about, the changes can show up differently. So Lewy body is a version of that. Parkinson's is sort of a version of that, depending on sort of where the Lewy body falls. So best, I would say, is going to be with the neurologist that's involved, if there is an involved neurologist. The unfortunate part about a lot of these conditions is that even for movement disorder specialists, it can be hard sometimes to determine the exact, we'll call it cause meaning diagnosis or change that's happening. And so often touching back base with that specialist, especially with, I'm not saying longer, but maybe broader or more detailed versions of symptom descriptions. As a social worker, we do something called AEB, as evidenced by. So if I were to say, my loved one's having falls, but if I were to say my loved one's having falls primarily at the end of the day when they stand up from a seated position and they fall forward, that is very different than there's just falls, or they're tripping over things, or they're missing things. And so as you are trying to get to sort of a root cause or a clarified diagnosis, sometimes those pieces of symptoms described in an improved way can be really helpful to narrow for the physicians that are involved to help the family narrow down specific types of conditions that are there.
The reason I'm asking is I was told that the various subtypes, I guess, I don't know, maybe that's not the right word for it, but it tells you something about where the Lewy bodies initially form and the likely path of progression, so that I, as a caregiver, might be able to say, if this is the initial place that they start, I might be able to expect these symptoms or issues to happen in this way. And I was just looking for more information on, first of all, is that a pipe dream? And so you've given me, just check with my neurologist who specializes in dementia.
Yeah, and definitely, I don't know if you're connected to a movement disorder specialist, but movement disorder specialists are specialized neurologists that tend to, in many ways, not always, but tend to in many ways be well-versed in some of these, especially differential diagnosis conditions, because it's what they treat. So they treat things that are under this umbrella, and because of the connection to Parkinsonianisms, they can have sometimes more experience with certain things. I have heard a few neurologists describe sort of the pathway of certain things, so I don't think that that is a pipe dream necessarily. I am just not equipped to answer that specifically, and I think it would have to be really provided by the neurologist who would be the expert in that differential diagnosis.
Good enough. Thank you. Appreciate it.
We have a comment from one of our favorite, often participants, and she's a provider, and she says, in my practice, the visual elements as well as the motor difficulties have always been significant clues to target a possible diagnosis of Lewy body dementia. Mm-hmm. We had a question. Any suggestions for when it's like a flip of the switch and person with LBD goes from normal to extreme agitation and can't be redirected, may start striking out, etc.
Yeah, fluctuations are intense and can be. In certain situations, I say start with caregiver safety, and I know that almost sounds insensitive, but I've had a couple situations where that is sort of the best place to start in certain situations, you know, get out of arm's reach type of thing. Not always is it possible, but when it is possible, can be really helpful to know if there's any kind of triggers or reason for the onset. And again, this may be things that the care partner isn't seeing, for example. So if it's an altered perception, like we've talked about, it may be something that's upsetting them. So whether it's a thought or whether it's something that they're sensing through their senses that's causing the upset, sometimes knowing that can help with some of the response or how we choose to respond. And again, I go back to the, if this were what I was experiencing then. I've had a few describe agitation as an expression of their depression. And so sometimes it can be important to speak to medical providers if this is something that is happening, where there is increased agitation, especially increased aggression, but increased agitation, it can be really helpful. Again, to try to get a encapsulated picture of when this happens and sort of what happens. And then definitely talk to the physician about symptom management of that. But it can be, like we talked, the dimmer switch. The dimmer switch we see beyond cognition. So for some, they'll describe changes to their movement, changes to their mood in a very similar way than they will with these fluctuations in cognition. So I'm so sorry that that's an experience, because as a care partner on the receiving end, it's almost like you got to keep one eye open to prepare for that. But again, get yourself safe. Reduce risk in the environment when you can. Access to sharp objects, things that may be thrown, things that may harm you. sort of have a mental action plan and getting yourself safe. For some people, sort of having a game plan of what that would look like. And it may include things like having an outdoor key, because sometimes the aggression may include things like locking all the doors. I've had a couple situations where, just making sure that you sort of thought through an emergency game plan of what that can look like. And then be prepared that if the police or emergency personnel are involved, that it may involve certain descriptions of the condition to those individuals, so that there is a certain, what we will call most appropriate level of treatment from those professionals.
I'm going to read one last question here. My husband had a mild stroke in June and has gone from mild Lewy to advanced cognitive issues and hallucinations. Is this change related to the stroke or just a coincidence?
Definitely cannot confirm or deny. Not a medical professional in that regard. However, I will give you a question to ask the physician. There is another kind of dementia called vascular dementia, VASCULAR, that can be associated with stroke. And one of the things that I would definitely share for people to remember is that not all dementias live in a vacuum in the brain. So people can have mixed dementias, not just Lewy. You may just have one that has a louder drum. Does that make sense? So it's screaming louder, but there's other changes in the brain, such as the stroke, such as plaques and tangles associated with Alzheimer's disease, that may also be having brain changes, which is leading to symptomatic progression. So I would just sort of note that down and see, take a look. There's some great information on vascular dementia. You'll find that a lot of the symptoms overlap with Alzheimer's and overlap with other dementias. So it might be a presence of a mixed dementia, but I would just check that out and talk to the physicians. And if we are closing up, can I say one last little thing if we're closing out?
Absolutely. And I've got a little housekeeping after that.
Oh, perfect. So really quickly, look at self-compassion as well. There's some really great research right now. It goes beyond self-care, because most people, if they're in the midst of caregiving of any type, and you tell them to take care of themselves, it feels just like one more thing they can be terrible at, I'll be honest. So I would take pause in that and look at self-compassion. So what little ways can you provide yourself space and grace to know that you should know what you're doing, to know that it's okay to struggle, and to know when to lean into support. I think it's very, very important. I see too many caregivers beat themselves up, including myself. My father has vascular dementia. So I find myself really hard on me, much harder than I would be on anyone on this call. I would give you so much grace, but I'd be pretty mean to me. So my reminder is, sometimes it's really great to treat yourself as you would treat your best friend if they were in the same situation.
Beautiful message. Brandi, I can't thank you enough. This was brilliant. I think people really enjoyed it. We've got a lot of good feedback here. For those of you who had put stuff in the chat room, we have recorded that. We can forward that to Brandi, but I think what would really be helpful is that we are going to send out a whole list of resources that Brandi has provided us, including the video from the Mayo, Minnesota and Hartford. And we will be sending those out with the post-session questionnaire. Now, there's one problem. If you got this number from somebody else, or if you got the link from somebody else for Zoom, you're not going to get those resources unless you register. So please call your customer service representative, the incredible Minerva, at 866-390-6491, 866-390-6491. And you will not only get the resources from this presentation, but you will also get the monthly calendar. We have one presentation left this month. A gentleman named, let's see, Jamie Heisman, who's an excellent presenter, very entertaining, talks almost as fast as Brandi, maybe about the same, and gives so much information. He's talking this time about moving away from codependency, which makes us all free. So you want to hear that one? That's this Thursday, the 28th. And I want to thank all of you caregivers for what you do every single day. This is such a tough job, such a tough job. So thank you, Brandi, for the excellent presentation. I've gotten many people saying it was outstanding. And I want to thank the WellMed Charitable Foundation for supporting all of these the podcasts, the speakers, the monthly calendars, everything that they do for caregivers in the country. And with that, I'm going to stop the recording and thank you all so much for being here with us today. Bye, everybody.